Hi. Okay, so thank you very much for letting me to come and present this. So this was actually a case that I had whilst I was working in the hospital transfusion team in Oxford. And it was a case that we wanted to just come and present because it's not quite what me. So I'm sorry, I don't have a picture of all the transfusion team. I didn't realise I should have put them in. So what I wanted to point out was that the was something that's been such a big source of hope and pride, I think, in Oxford, is the vaccine that was developed on our site, and it's something which certainly was extremely exciting to be witnessing through the windows as I was working in the building opposite where it was all happening. So I want to talk to you about a 67-year-old lady who is a patient that had been coming to haematology for a long time, since being diagnosed with myeloma back in March 2014. And she'd had lots of different treatments for her myeloma, and she had unfortunately been progressing increasingly quickly through different rounds of treatment, and she had really horrible genetics now that was driving it. She also had a background of Crohn's disease, for which she was suppressive antibody treatment, and she had a complication where she had a colovesicular fistula, which meant that she was increased risk of getting urinary tract infections. So she was admitted in August and with a history of 10 days of vomiting and diarrhea. When she came in, she was in a very sorry state. Her kidneys were failing, her bone marrow was failing, and she didn't have many platelets or red blood cells. She was diagnosed with E. coli septicemia, and also we found that she was progressing from her myeloma. Thankfully, she responded to a course of intravenous antibiotics. She was also put on hemodialysis to sort out her kidneys, and she was given plenty of red blood cells and platelets as transfusions to support her whilst we're trying to get on top of her myeloma once more. She was doing rather well. 2 weeks into the admission, she had a bit of a hiccup where she started spiking a temperature again, but seemed to be responding to antibiotics once more. There was no kind of source of this infection that had come back. And she was actually, everyone was kind of looking at how we were going to get her home and manage her dialysis in the community. And then she had a prophylactic transfusion of platelets. 30 minutes later, she was looking really bad. She'd suddenly become short of breath. She was quite distressed by this, very anxious. She was breathing very fast. She required high amounts of oxygen on 15 litres on a non-rebreather. She'd become tachycardic with a heart rate of 130. Her blood pressure was through the roof. And listening to her chest, the doctor said that there were crackles throughout both lung fields. And she was a bit worried that also she developed some facial swelling. So she was treated for anaphylaxis, and she was also treated for fluid overload, and they got a chest x-ray. Here it is. So it's the kind of chest x-ray that keeps you awake at night. It's horrible. You can see that there's patchy infiltration throughout both lung fields. You can see increased vascular markings, particularly on this side. And the diagnosis at this point, we were thinking this looks like someone who's gone into crushing pulmonary edema after having a unit of platelets. It's a bit odd, but that's probably what's happened. So we thought, yes, she's having dialysis, but while they're doing a good job, maybe they didn't take quite enough fluid off her last time. She's clearly got evidence of having very high blood pressure, high heart rate, and this has happened all very quickly after the transfusion. So if you go through your shot reporting criteria, she ticks every single box. So she has acute or worsening compromise of her breathing. She's got evidence of pulmonary edema, both on physical examination and on a chest x-ray. She's got evidence of hypertension and tachycardia, evidence of, well, we're thinking maybe she's got a positive fluid balance. And I can tell you that her BNP was highly raised. So she's got pretty much a full house. So she went off to intensive care. She was intubated. She was put on a continuous filter, which was acting as her kidneys, and they were able to offload fluids in this way. She was started on a labetalol infusion to help with the blood pressure. They assessed what her cardiac function was, and it was doing very badly. Globally, the left ventricle was not working very well, but there was no specific areas that had been affected that would suggest an ischemic infarct. So we thought that this was probably most in keeping with someone who's got fluid overload. And then one day later, she was doing a bit better. We managed to get her off the tube, and then she was still requiring a lot of flow, though, on high flow nasal oxygen. So her lungs were still clearly not working very well. So she continued on filtration for another few days, where they were maintaining a negative fluid balance, and she was stepped down to the ward. So she was still on high flow nasal oxygen though. So we decided to do another chest X-ray. And it still looked very similar. So if this were to be TACO, we would expect this all to have completely resolved. And the breathing should have come back to normal within several hours. The chest X-ray would have returned to normal probably within several days. But this is definitely not normal. So what are we dealing with? So I think there's definitely evidence that you've got an acute respiratory distress syndrome with the ECG, with the chest X-ray changes and the hypoxemia. But what's driving that? We know that she had an infection that had come back, but it didn't feel like a respiratory infection, and certainly to get so quickly worse is very unusual. We've ruled out an ischemic event in the heart, so we're not 100% sure what we're dealing with. So what else could it be? Now, it's very hard to say that this was not related to the transfusion. I mean, it certainly looks like a transfusion reaction. It all happened for a patient who was well to being very sick within 30 minutes of a transfusion. We didn't have any positive blood culture, so we don't think it was a transfusion-associated infection. So we're left with these possibilities. So Trali was definitely higher up there on our differential. Now, looking at what it's the criteria here, yes, there was hypoxia. Yes, there was bilateral pulmonary infiltrates, and it was within 6 hours of a transfusion. But there probably was evidence of circulatory overload. There was certainly evidence of acute heart failure for some reason, and then presence of HLA and HNA antibodies. So the current process for getting these is now slightly changed from perhaps when I was previously learning about it. And I'm sure many of you will be aware, but there is now a panel that discusses the potential trial cases and whether or not to run these tests, and the implications of what happens if antibodies are found. So this was discussed with the panel, and they decided that actually, on the basis of what we've been finding, it was that it didn't sound sufficiently like Trali to warrant it. So we didn't. I think we might have sent for HLA antibodies anyway, but we didn't do HNA antibodies. And so, in the end, well, we reported it as TAD. So, as you can see here, TAD. It's a bit of a dustbin diagnosis where lots of things get chucked in which are probably just don't fit into the other categories. So certainly there was an acute shortness of breath that doesn't fit with TACO or Trali. And although there was a little bit of a concern about there being an allergic reaction, I think the blood pressure and tachycardia, well, blood pressure especially, and the quick response doesn't quite feel like an anaphylactic reaction. And so I think that in this term, there's probably some very, very interesting pathology occurring, which she fits into this criteria, because there is certainly evidence here of immune activation, which is probably what's causing these pulmonary infiltrates, but maybe through a different mechanism than Trali, and something that has also had an effect, a profound effect on our circulatory system. So unfortunately, we are still scratching our heads. We don't know exactly what happened, but she has had a number of transfusions of red blood cells, platelets, since then without any further complication. And so we are just hoping that it doesn't happen again. But it'd be interesting to hear people's thoughts on the case and whether there's any recommendations that we can bring. So my conclusions or key messages would be that shortness of breath and hypertension do not mean TACO all the time. It is difficult to diagnose trially, and this can only really be made through a panel in NHSBT. And it's always important, if you've got a sick patient, that you escalate to intensive care early, regardless of what the diagnosis is. There we are.